Okay, so we're running a little bit behind. So we thought we would roll straight into the provider panel next. But during that time, there's coffee and tea over there, and people can get up as needed to take a break. Get a cookies and teas, pick up your kids. And then we'll get the providers up on stage, and that way we have a little bit more time for people to ask questions.
Awesome.
Does that sound good for everybody?
Thank you again for all your help. And if you have any feedback for me, I'm welcome. I was talking to Jack. Yeah. Yeah, no, I'm not used to these
Like, in retrospect, maybe like having their staff would have been better just for the seamless transition if they had changed. And like, we would have, we chose here because children's is great, but people applying in and staying up there, it's very cool.
Yeah.
It's kind of a crappy location, so then we decided here.
One more thing.
We're like, oh, we want our AP, but the system is just,
Yeah.
you want it to go.
And I think I would have gotten here earlier. It's always trending. So, yeah.
I have nothing bad to say, really.
Okay. Yeah, you deserve it. You can run around. Yeah.
Okay. That's great. So your answers today. That's wonderful. Does anyone have any questions right now? I'll run around with the mic. Yeah, okay, great.
So I have a couple of questions for the healthcare providers. One relates to the presentation on infectious disease. What is the role for doing asymptomatic urine cultures on patients with bladder extrophy? I know it is done, but it kind of contradicts a little bit of what you were presenting.
Let's see. Thank you for the question. The easy answer is to say, don't ever do it ever. That's the easy answer. I think it's because when a culture is done, there's a general association that a positive culture means infection needs to be treated. In fact, in certain patient populations, in certain settings, it doesn't necessarily mean that there's an infection. It can mean colonization. And understanding colonization can be helpful in preparing for infection. So it's kind of nuanced. That's the long answer. I'd say the short answer is don't ever do it ever. If there are no symptoms, don't do it, because it could lead into the temptation to treat, and it may not be necessary. But it may have value in planning and knowing. So, for example, I think this has happened in a recent. We had a family who was going to go on vacation, and there had been some recent infections, and so we did a urine culture to see what the patient was colonized with to prepare an antibiotic for them to take with them on their trip. Not to take now, not to take at the time of the culture, but just knowing what the state of colonization was. So it means having a shared understanding between the ordering provider and the family, knowing what it does and does not mean.
My second question is about screening for cancer in males who have had a bladder augmentation with And I guess my question is that done through cystoscopy? At what age does that start? And how do you actually mechanically do it in people who have a mitral valve in a very tight bladder neck?
I can start by asking. I think the issue is it's a there's a long answer to this. It's controversial. I think the most recent study that's looked at is from the Mayo Clinic, where they've actually compared patients who are on intermittent catheterization, patients with augmentation. The risk of cancer was not different in those two, or not statistically different. In the past, we used to catheterize, and wait for the lag period is around 10 to 15 years, and wait for 10 to 15 years after an augment, and then perform cystoscopy on a yearly basis. There are some groups who do that on a regular basis, some don't. I think the studies are pretty controversial, and some have been. The fact is that there's no comparison. They haven't compared. That's the most recent study that was published at the Mayo did not show a difference. Having said that, I think the gastric augments are a different group of patients. The patients that in the 2000s have had gastric augments or stomach augments. At that point, it was felt that gastric augment was a really good operation because, one, it doesn't the stomach does not produce mucus, it produces acid and therefore kills those bacteria. But there have been a lot of issues related to gastric augments that we're seeing right now that those gastric augments can develop into cancer. The other thing also is when we do cystoscopy once a year, is that enough to detect cancer? Because cancer can go pretty quickly during that 1 year, and when you scope them again the next year, they may have or if you discover cancer, it may not be cured. Most of them, if you look at the data on augmentation of cancer, most of the cancers that are detected are not cured because of the past.
I don't have too much to add because I agree completely. I used the same article from Mayo Clinic, which was by Higuchi and Usman, as good evidence and long-term data that the augment wasn't necessarily an increased rate of cancer, although overall there's a higher rate of cancer. It's in the 4% range for people who chronically catheterize, so it's not trivial, but annual cystoscopy wouldn't seem to detect it any earlier than watching for signs of blood in the urine and watching your ultrasound images of the bladder as part of it is the recommended surveillance. So you don't have to scope that.
And just as to your other question about scoping technically, so for folks who do have channels, they can be scoped. You might just need a slightly different setup as far as the equipment, but cystoscopy can be done.
I have a question related to UTIs. And when my son was young, so this is 30 years ago, we were given something from Children's Hospital that had recommended foods and unrecommended foods to have in his diet. And we were also vegetarian. And he has had no bladder infections in growing up, and he's 32 now. And I'm just wondering, is that still being given out, or is there a refined analysis of why this helps or hurts?
One, I'm not aware of the handout. Two, I'd like to find out if you have a copy. Can you share it with us? Yeah. What I can say is that on the one hand, the field of understanding the microbiome has occurred since then. It's a new field. And we understand many more things in theory we understand a lot of things in theory, and we publish a lot of papers about it. Getting from theory to practice takes a long time. It takes at least 15 years for things to really get from journal articles into practice. And I would say that as an infectious disease doctor, as a mainstream medicine practitioner, I would say that nutrition is not a strong area for me or for us. So I'm kind of coming at this from a very niche point of view, thinking about kind of nerdy concepts about the microbiome. I think, from what I know from my gastroenterology colleagues, we're nerdy in very similar ways about the microbiome. There are foods that are likely to be beneficial, and there are things that we eat, food, laboratory creations, maybe that object you lifted, that probably are not good for gut health. And I think, the links are, it takes good science as an individual to know what factors are protective or harmful in your own life and practice. It's hard to see results. These are things that really need to be studied on large numbers of patients. But I do believe that nutrition, diet is something that families do have under their control. So right there, it's really worth being thoughtful about it. And I hope that we can get to a bridge between the theory, nerdy stuff, and really informing good gut health promoting diets. You can certainly find it on the internet. You can find a lot of things on there.
That's a very good comment. I'm gonna add that Seattle Children's does have a resource. I cannot address when it was last truly reviewed and updated, but I might be recommending that people on this committee are gonna be voluntold to review that. But yeah, we do have it. Give my now adult son to remind you.
Hi, just a couple of questions. So we're from British Columbia, Canada, and our son was born with cloacal extrophy. So after he was born, or our urologist has used the modern staged approach for his repair, and I don't even think we knew about the complete repair approach. And so the questions are twofold. One is, do you find more and more centers moving towards the complete repair? And two, for those who are using the modern staged approach, it was mentioned earlier, Dr. Google may or may not be your friend. And so for the information that I've received about when certain things should be happening and when that's not following suit, what advice can you give for those anxious parents like myself that haven't had certain things happen when Dr. Google says they should?
Pretty good question. You've got two great pediatric neurologists on PC Children's.
Yes, they say hi.
and I think your condition is different. Someone was born with coeval exophy, which is totally different. We discussed that because the hair is pretty much similar. There's it's a stage repair where the bowel is. So in the past, what they used to do is they used to incorporate the hindgut into, so they have two bladder halves, the bowel, they used to incorporate the hindgut into the repair. So they found is that having a colostomy is better than having an ileostomy from a standpoint of fluid management because the colon absorbs water. And so now the initial operation is separating the bowel from the bladder, bringing it up as a colostomy, bringing the two bladder halves together, and then at a later stage closing it. But as far as both the modern stage repair of bladder exophy and the complete bladder exophy repair have similar outcomes. There are some people who, in our group, for example, our multidisciplinary group from India, one of the people within that group believes that in certain situations, the stage repair may be a better repair than a complete primary repair. In some situations, so if, for example, the bladder plate is small, if you run the risk of having significant upper tract damage if you tighten the bladder neck. So doing a stage repair without tightening the bladder neck may be an initial first step where the bladder grows, and then you can do the stage repair. So the outcomes of these two are the same. Most people, I know, it depends where people train. As people that have trained in Hopkins obviously do the stage repair elsewhere, but looking at the states that developed the major centers of excellence that we have, most of them do the complete primary repair. And as I said this morning, it's a misnomer because it's really not a complete primary repair. Those cases do need multiple other surgeries after.
For cloacal extrophy though, you would do a complete primary repair most often? Because we wouldn't in our group. We do exclusively stage repairs for cloacal extrophy. I'll give it back, the mic back to you, but we would do a staged repair where we would do the bowel separation first, and not necessarily immediate. It might happen at days or even weeks of age to ensure that the child was eating and nourishing before we did any surgery. And then we would do the urinary tract reconstruction often months later, even up to a year later, waiting for eye conditions to be ideal. So in our three groups, is always stage. They're going.
There is stage. I think the issue is the urethra is small, and most patients with cloacal extrophy, continence is most likely not going to happen. So a lot of these cases will require some form of reconstruction.
What are your thoughts on bulking agents?
Well, I'll start off with the Rich Grady story. So Rich Grady was a big bulker. He used to use a lot of bulking agents. And when we looked at our data long term, so bulking agents, I think, are beneficial in those patients that have those marginal bladder capacities, the ones that you hear, well, I'm dry at night. When I'm sleeping at night, it's only when I wake up I start leaking because I'm walking around. And then you measure the bladder capacity, and they're an adequate bladder capacity. Those are probably, and when you scope them, the bladder neck looks pretty pliable and it's not scarred. Those are ones that I would consider doing, injecting bulking, but unlike Grady, I would try it once. I think Grady would inject quite a bit. There is a new material right now that's really not approved for use in pediatrics called Voltamate. The adults urologists feel that that may be a better bulking agent than what we currently using deflux. And so it's something that I would try at least once if the bladder capacity is adequate and the bladder neck is nearly coapted, but not completely.
I use it similarly to what Dr. McGarian described. I am a fan of it for select cases where somebody is achieving capacity and they have a nicely constructed bladder neck so they can hold their urine at night. But when they're active, they start to leak. And I do it for a couple of reasons. One is that coapting the bladder neck tighter gives them better continence. I think it also inspires them mentally. Sometimes they've given up and they're not trying to achieve dryness anymore because they think it's unachievable. And I bulk them and get them on a very structured, scheduled voiding program, and they achieve dryness. And mentally, it shows them they can achieve this if they work at it. And so I think it also inspires them to work harder to achieve dryness. If you give them a taste of success, they will want more success. But some people get defeated and lose that motivation. And so I think bulking agents help. I use macroplastique. I think it's a little more viscous and maintains its volume a little better than Deflux, but that's opinion. That's not based on proven fact.
And just to add to that, we were talking now about bulking agents for the bladder neck for those who are avoiding. Additionally, bulking agents also can be used for those with channels. Kind of variable success, about 50% will have some response to it, but it's often a decent option as a invasive type of procedure before considering full revision.
I just want to add one additional sentence to it. And the other reason I'm using it is I'm trying to stall a patient who's giving up to get to puberty, which I said earlier, I think puberty is a period where the pelvic floor muscles will kick in too. So I think if I can just eke them along a little bit longer with a bulking agent, then I'm hopeful at puberty other factors will kick in.
Hi. First of all, I want to say thank you guys, and all of y'all for putting this on. And my son is 17, and last one we came to is when he was 2. So this is kind of cool. Well, thank you. And puberty is wonderful for all of you guys that have the younger kiddos, and things change like crazy. My question has to do with that. He's 17, we're looking at future things, reconstruction type things, but also the transitioning. We're from Oregon, we deal with Dornbecker. What's your recommendation for getting into the transition and finding an adult caretaker and going forward from here?
Thank you. That's a really good question. I think one of the we do need transitional care, and there are different models of transitional care. I think the best model that I think works best is to actually incorporate a transitional urologist, adult urologist into pediatric practice so that what I hear from families and patients, they're really afraid of getting out of the children's system because the children's system is so supportive of them and afraid to get out of that system. And I think bringing an adult urologist into that system, allowing that adult urologist to work together with the pediatric urologist in providing the care so that the family gets to know that person by the time, for at least 4 years, and by that time, they're used to that person, hopefully able to transition into adult care. I think that probably is the best model, and that's one of the models trying to implement actually in Seattle. I'm working with, we have one adult colleague who's really interested in doing transition care, and you do have to have these individuals. It's really eye-opening to see that there are a lot of providers out, adult providers out in the community who know nothing about intravenous, know nothing about orthodextrophy. They have ACEs and other catheterizable channels. And so having an adult person incorporated in our practice is probably the best option in my mind.
Something to add to that would be something I feel is good across the board, not just talking about transition, but having open communication and preparing kids to move forward with that and kind of be involved a lot more. And it can be kind of a step-by-step process. So having kids as early as 13, they can start seeing their own mind chart and having their own conversations and seeing things like that. Having them be more involved can be a really good thing, so that by the time they are essentially forced out of the pediatric area, they're as ready as possible. And something that I barely touched on earlier was some of the information to kind of have ready to go. So having your cervical history, your medication, being able to have your kiddo independently be able to relay some of that to themselves, because once get to that adult area, you know, they're not gonna be checking in with the parents saying, hey, is this actually accurate? And so there is a lot of that's handled, I guess, in pediatrics, and so that's just not the same in adult care. And so making sure that you can prepare your kids as much as possible, having those, you know, the documentation even of the history of these things to know to talk about, and to bring up how you talk. It's another thing. So kind of doing that step by step, I think, in many ways is really productive.
That's kind of where we're at right now, where he's having the conversations, teaching him what his history is, so he can ask the questions. It's a learning process for all of us.
From a GYN standpoint, I generally start having the conversation with patients about transitioning to adult care when they're juniors in high school. You know, like, what are you planning to do after high school? Like, are you looking at a, you know, certain part of the country? For us, we're a really small community. We all know each other. We have a listserv, and it's one of the most frequent things that you see is, hey, do you know anybody in this area who is familiar with political extrophy? And so then, as you're transitioning, like your pediatric patient, you're like, oh, I know this person in the state that you're gonna live, and then kind of connect them that way. Another thing that we're doing through other groups is just simple transition cards. So from the GYN standpoint, it just says, I was born with whatever, my anatomy is this, my surgeries are this, and then anything that's just really kind of critical, like under no circumstance should I have a vaginal delivery, or, you know, things that are really contraindicated. One of the things we're working on too is just having even a QR code where you can kind of scan it and it links to like that ASRM Mullerian anomaly picture that I showed, because, you know, wherever you end up, who knows how familiar they're going to be with those terminologies.
A lot of the medical resources like this is also have the their child to the app and help them on their file.
So we struggle with transition. I do in my practice to find people who can care for the children with complex surgeries in childhood. There are fellowships who train adult urologists in complex reconstruction. So recruiting one to your practice or to your community would be extremely valuable. But in the interim, I don't transition. Our hospital doesn't have a rule that we have to transition. I mean, I would look at you and say, you sure? But we don't, and so I find my practice is getting older as I get older. And I just wonder if old pediatric urologists are gonna be the transitional urologists for their patients as they get older, and we just grow old together. And that's kind of how my practice is evolving.
One quick thing I also want to add is that any research study out there shows everything we've mentioned already as barriers for patients to transition. A big one, a factor that people don't like to talk about, is insurance, right? And just the logistics. So with the ACA, most kids can stay on insurance, you know, later now to the 20s, but that's not always the case. So I think starting early with just, you know, you've been navigating the medical system, insurance, scheduling appointments for years, right? So then involving them early in the teenage years is sort of saying, this is how you make an appointment, you know, you have to do X, Y, and Z, or this is what insurance means. I think it's really, really valuable.
Training folks to be able to ask people questions. All that is required on us to have. The very first question we asked Dr. Mitchell was, why do you always
And you look good a lot of times. Yeah, well, that's the.
First of all, thank you all for being here. This has been a tremendous conference for us and our first one with ABC. And I've learned an awful lot, so thank you all for being here. I was very encouraged and intrigued that, you're finding that with puberty, there is improved continence that may not be achieved in the younger ages. And I know that most of your experience is in the complete stage repair, and you have done the multi-stage repair from Hopkins, and I'm wondering if you have any data or experience that would indicate that there may be improved continence after that kind of procedure.
The philosophy applies to both surgeries. So, you know, we communicate very closely with Dr. Gerhard at Hopkins. And so we're all part of this same mission to improve things. And whether you do it in 1 stage or 2 stage, ultimately, the pelvic floor muscles will help with continence. And so I think it's the exact same expectation that at puberty, continence should improve, even if it was in multiple surgeries or stages. If that pelvic floor was reconstructed well, you know, you gotta have the muscles reconstructed nicely too, to have value from pelvic floor strengthening. Which, you know, Dr. Gerhard does extremely
Probably, I've seen some of these patients go through puberty, and I've seen several of Dr. Mitchell's patients that were incontinent before, and once they start going through puberty, they all of a sudden become continent. I think those are usually patients that have adequate bladder capacities. They tend to go to the bathroom every hour, hour and a half, are incontinent between. I think the patients that are totally most likely may get better, but they will not completely resolve at puberty. So those patients that are on the brink where they basically go 1.5 hours are incontinent, and then once they go through puberty, they do become continent. We've had several of these patients in this disease.
I can probably ask that question about So do you have a particular time that you recommend for bladder neck reconstruction then, like pre-puberty, post-puberty? But I know there's so many variables such as bladder size and things like that, but just kind of thinking about taking advantage of that puberty period.
I think the answer the 3 words: shared decision making. I think that's probably the most important component, is really engaging with families and seeing what they have. I've had kids that have said, that really doesn't matter to me, I'm okay the way I am. And then they're 10 years old and they want to try. I think working with the families is probably the most important thing. There's no specific time that you should recommend the bladder neck reconstruction, because you can't do anything worse than doing the bladder reconstruction with a child. The patient is not ready for it, or the family is not ready for it. I think you've got to have the family ready for that in order to be able to probably get the best success rate for these operations. If they're not ready, it's not worth doing.
I guess I have a follow-up on the not ready. And then I had an original question too, but just a follow-up.
I think it's a family's readiness and the child's readiness to gain confidence.
Put effort in, or what do you mean by?
Effort, catheterization, be able to catheterize for some reason if they need to catheterize a lot. If you talk to a lot of times with the bladder neck reconstruction, as I said this morning, we're pretty much tightening the outlet. And there's no real science behind that of how much you need to tighten. We actually can tighten it over a certain catheter size, which works most of the time, but if you look at the outcomes, they're successful in 60–70% of the time. And so some of us would tend to tighten even more, but then also do a vitrophenol, just in case child is not able to catheterize them to void volitionally, they can catheterize with vitrophenol. those are things that I think need to be discussed with the family to try and figure out what is best for them, and when they would like to have this. It's a big commitment from the family and.
Thank you, that makes it clear. Not sure if this is how to ask the question, but there's been talk about letting the bladder grow. Is there is there a known age when the bladder grows the most, or it's like, it's not growing, and so now we're done waiting?
So there's not a specific age. And there's a lot of factors that go into it. But first of all, there's gotta be a well-constructed sphincter for the bladder to grow. If urine is just flowing continuously through the urethra, there's no stimulation for the bladder to grow. So for me to judge how well a child's bladder is growing, first of all, I gotta see that there's some outlet resistance or sphincter tone. If there's that, then you look at their age, are they 5, 7, 12, 14, what age are we talking about? And if the bladder, if they've reached an appropriate or a reasonable age, a number of years for the bladder to grow with a good sphincter, then we're making progress. But if you have a well-constructed sphincter and the bladder holds 30 milliliters and it's just not growing, the way Dr. Mitchell answered it for me just recently with a patient whose bladder wasn't growing is sometimes a perfectly well done surgery doesn't turn out the way you wish it would. And some bladders just inherently do not have the elasticity to grow with cycling, and then we have to change strategies, and we do that early. For this patient I'm referring to, this child is just several years old. The bladder's not growing, but it's got such poor elasticity that the kidneys are dilating, it's affecting kidney function. We're just not gonna see this patient's bladder grow, in my opinion, because in spite of our best efforts, we should have seen a different outcome, and we certainly shouldn't have seen dilation occurring the way it did. So, in short, it's a very individualized question for each patient, and I don't think I can give you an age.
I think we've tried to predict if their bladders have been good. We cannot predict. We can actually see tiny little bladders that you reconstruct and they grow over time. Large bladders that do not grow. There's no real prediction at the time of birth or time of reconstruction which bladders are going to grow or not. I mean, that's something we may need to look into further, into what these bladders look like from a microscopic standpoint. But right now we cannot predict which bladders are going to grow.
Kind of on that topic, what is the strategy for those who have insufficient volume in a bladder to augment that? What in terms of like the tissue used, or is that just an individual decision, or is there some sort of strategy that seems to be more successful for augmenting?
I think, I mean, we have this volume of 100 ml as being kind of the magic number that we use. But if bladders are small and have not grown over time, and you don't have upper tract damage, because that's a totally different story. If you end up having a small bladder contracted and you have hydronephrosis, which basically means that this kid is prone to kidney failure, then you may need to intervene early. You don't have that. The bladder is small and has not grown. Again, I think at that point, then the only way you would gain confidence by doing the catheterizable channel augmentation. And so we're looking at the magic number of 100 mLs that you can possibly try to reconstruct the bladder neck without an augmentation of the bladder, hoping that the bladder neck tightening will allow the bladder to cycle and grow over time. So a lot of times when we do the bladder neck reconstruction, we will tell the family continence will not happen right away. They may do continence after, it may take up to a year. after bladder neck reconstruction to actually gain continence. Because bladder needs to regrow, because we're using part of the bladder for the reconstruction. If the bladders are smaller than canals, then chances of those bladders, you cannot do bladder neck reconstruction if you create tiny bladders. So those are the ones that will need to be augmented with the continence version.
And I think you also asked about which material specifically you feel like. So when the decision is made for augmentation, whatever the criteria are, I think you have primarily two choices of large and small intestine. And I think they both work well. I think there are subtle differences between the two, in my opinion. Other people might feel more strongly, but I use both small and large with great success when augmentation is necessary. We rarely use gastric augmentation anymore. Tissue engineering has been in evolution for decades. I don't foresee it becoming applicable to general practices for a long time yet. I may be wrong if somebody knows more about tissue engineering currently, but I don't think it's happening in the near future. So I think intestinal augmentation still remains the standard when it's necessary.
Great. We do have a couple of questions from online, so that's exciting.
But I get to read these, that's fine.
Okay. The first one was about bulking agents. This is, what was the question about bulking agents? I guess we'll go back to the film for that one. Let's get to this next one. If the person online that talked about bulking agent wants to clarify, please let me know. The next one is CCPR sees their patients for life. Is there any plan for Seattle Children's to adopt this process?
We tried. We can get exceptions. We actually, any person who's above age 21, and we do have a few children that have specifically cloacal extraphy cases that are more complex and require multiple specialty care. Those are the ones that we can get exceptions and see them after they're older. But Seattle Children's is very uncomfortable with us taking care of kids above the age of 21. They have to actually request to see them over 21. I think it's different in the one.
It's a little different and it's not. So I can agree to see patients, and the problem is the other specialties might not necessarily either. So then I'm off on my own sometimes at Children's Hospital, especially if there's surgery for your patients in the hospital. The nephrologist, hardline 18, won't see you. So I might have a patient in the hospital who's over 18. If I needed nephrology help, no way, no how, it's a hardline no from them. Same with my GI colleagues. If I needed help from a gastroenterologist while the patient was in the hospital, it would be a hardline no. So it puts me in a predicament. And so, so I do it in select circumstances. My philosophy is to ask forgiveness, not permission, but I take a risk that I could get in a jam if I needed help from other specialties who wouldn't see a patient over 18. And so it's a tough time right now for transition to adulthood.
I do want to also add that we here at Seattle Children's are fortunate enough to have the transition program. So we're actually really working closely with the adult urologist who not only comes in and spends at least one visit with you before you transition over, but like is actually sitting with the urologists here and coordinating your care with them. So before you move forward, you're able to do that. Also, in kind of thinking bigger picture, as a 35-year-old person, would you really want to be at a children's hospital admitted and having, a lot of these other people taking care of you for if you were there for a urology issue, that our team would be able to happily take care of you very well. But the rest of the team, we're not the only touch points of those things in that place. And so I think kind of looking at also, bigger picture, we're not the only people taking care of you, kind of recognizing that there are benefits to being at adult care places. And if there is question, they are always able to welcome to consult with our students too.
I think that there's also the issue of billing when you create clinics like that, because you have an adult urologist and the pediatric saying, well, they cannot bill twice, they have to bill once. So we have an agreement with the University of Washington, adult urologists, basically alternate billing. Which basically means that one of the providers does not get paid for that service.
Great question. I know we need to transition, maybe one more question? Move on. Adventure last one.
Yes.